right?
Okay.
Okay, hi. I think we're ready to start. Given a couple minutes for pizza. Do you want to introduce Santana? You want me to? Go for it? Okay. So this is the second of a series that we have on implementation science. My name is Katie Rizzolo. And then with Kirsten Ostad over here, and I didn't ask how to pronounce your last name.
You got it.
Okay.
You got it.
So we'll be presenting on implementation science models and frameworks. There we go. Oh, it's got the funny slides. I'm sorry, I couldn't undo that. And just if you're on Zoom, if you have any, if you have trouble hearing me, let us know. So first of all, like who is CIIS? We are the methodological hub for implementation science here at BMC. And we offer guidance, support, and innovation in research design, and also education like here today on implementation and improvement sciences. There's two main ways to kind of engage with us. One is you figured it out already if you're here. This monthly educational seminar that we hold. And then two, if you have a research idea and would like some thoughts, feedback, or collaboration, including implementation science, we do research consultations as well. We have a website down here, and then we also have email address that I believe when you signed up, you have this email address now as part of your, so it should be in your email already. CIIS, this is the CIIS cohort right now. Our fearless leader is Marilyn Drinoni, and then Santana here is our assistant director, and then Kayla, who's right here, is one of our research specialists. And then we have a broad number of people working on different projects concerning implementation science. Shayna Burrows is in infectious disease. We have Kirsten in family medicine. Gabby Cordova Ramos, who's in neonatology. May Elansari is in developmental peds. We have Catherine over here in endocrine, and then I'm in nephrology. So a lot of different kind of clinical backgrounds, but we're all working on implementation science methodology, which makes it for really fun meetings, in my opinion. And so we said we do this once a month, kind of different topics within implementation science. So this is kind of other topics we'll be covering throughout the year. The next one will be November 9th. So mark your calendars if you're interested and we don't scare you off. So let's get going on implementation science frameworks and models. So we're going to do a couple things today. The first is to define theories, models, and frameworks and explain the rationale behind their use. Second, we'll talk about how you select a framework, how you understand kind of the range and scope of frameworks and theories, and then identify resources for model selection. And then we'll talk about how to apply these frameworks, how you can combine and adapt them. And I'm giving the first part of this, and I'll say it's a little bit kind of like, I guess vague, but it becomes very clear with case examples. So Kirsten will be giving some case examples about how this has been used in different projects here at BMC. So first, kind of big picture, why use a model or framework? Theories, models, and frameworks provide a method for identifying, understanding, and operationalizing the phenomena of implementation science. Kind of provides the backbone for a lot of studies. And so it can kind of operationalize and help you understand how to implement the thing you want to implement. Frameworks can help research in a number of different ways. They can help with study design. They can help with thinking about outcome measures. They can help you think about how to conduct the research and then how to replicate and scale the research. Okay. It can inform future research and then allow you to generalize your knowledge. And so all of these kind of frameworks can help with all of these different areas. So first we have to kind of take a step back and think about what are the differences between theories, models, and frameworks. And if I had to choose where this gets a little vague, it would be this slide, because the differences between them, it's more of a Venn diagram, so much as separate categories. Kind of a theory is a wide set of analytical principles that are designed to structure observation and understanding and our explanation of the world. Whereas a model is a simplification of a phenomena and might just be described as like a theory with a more narrow focus. But the model is not explanatory, it's more descriptive. So you'll see things described as models and frameworks almost kind of used interchangeably at times, but it does kind of depend on whether you're looking for something more concrete or whether you're looking for like descriptive versus explanatory. And then lastly, a framework is an overview of categories such as constructs or variables that might categorize a phenomenon, but doesn't necessarily explain the causation between relationships or identify hypotheses. What you'll often see here is frameworks are presented pictorially or in a diagram. And so we'll go through a few examples because when I read this, it seems a little vague, and I'm sure it does to some of you as well. So first, to think about frameworks can seem really overwhelming when you see a giant list of all the different ones that exist. There are a lot of them. So breaking them into three categories of process, determinant, and evaluative frameworks. So the first is process frameworks, which are often used in early stages to think about a how-to guide to plan and then execute your target implementation. It may show a stepwise sequence of the different stages you need to hit. Determinant frameworks are often used in a different way to examine the factors that might impede or enable the implementation process. So a common thing you see, throughout the literature is barriers and facilitators. You can use a determinant framework to help you kind of categorize these. It's often helpful in the formative work before you actually go in and do the implementation to think about what approaches would cause your implementation either to succeed or fail. And then lastly, evaluative frameworks are often used after the fact, but can be employed at any point to kind of think about implementation outcomes that you want to measure. How are you going to evaluate that your implementation was successful? And so I really like this diagram. This is from the University of Washington's website, where they kind of showed how there's these different frameworks can be grouped into different categories. So process models on the far left helps describe or guide the process of translating research into practice. And we've listed some of the common frameworks and models underneath in red. So you can see there's a lot of them. And we'll talk a little bit more about how you decide which ones to use. Then there's a couple different ways to think about explain what influences implementation outcomes. So these might be like the barriers and facilitators. And so determinant outcome frameworks can help with that. A very common one used here is CIIS, for example. But there's others like classic theories and implementation theories, which we won't talk as much about. And then lastly, evaluating the implementation. You see a lot of these as well, like re-aim is a very common one that's used to evaluate if your implementation got the target outcome you're looking for. And so now we've kind of described why we would use frameworks and what they are. So we're going to move on to talking about how you select a framework. So first, kind of broadly thinking about what you want to learn before you start delving into which framework to use. What are your outcomes and how would you define them? Are they defined in the framework that you're thinking about using and how you would measure these outcomes? And then the framework also helps you to think about if there's any outcomes you're forgetting. You might be focusing on one aspect of the outcome, but forgetting other things. So frameworks help you kind of be more robust. So 3 different things to think about when you're choosing a framework are construct flexibility, dissemination versus implementation focus, and then what level of intervention you're kind of targeting. So first, construct flexibility is kind of understanding how broad to operational, like narrow versus broad, the framework can be. There are some frameworks that are for a very specific purpose, and there are some that are designed to be used quite broadly, amongst a number of different implementations. So for example, a broad construct is usually loosely outlined and has a very flexible application that can be used amongst a broad array of contexts, but there's more responsibility on the researcher to think about how you operationalize this for your specific study. So there's a lot of different definition examples here, like diffusion of innovation or community-based participatory research, very broad, but can be adapted. Then there's operational frameworks that are very concretely and clearly defined and might even have like a step-by-step process for use. So some of these might be like the health equity implementation framework, for example, that's targeted specifically at health equity. So thinking about this a little bit more can be helpful. And the second thing to think about is dissemination versus implementation. So dissemination is the study of how to spread evidence-based practices, whereas implementation is identifying strategies to promote the uptake of these evidence-based practices. And a lot of these frameworks differ in their degree of dissemination versus implementation. Some of them cover both, some of them cover one. And then lastly, thinking about the level of intervention. For example, are you targeting patient level behavior change, or are you targeting community implementation of your target intervention? These are going to be different areas, and not all frameworks target all of them. And so thinking about what setting you're hoping to use your implementation. This is what I don't like. It just changes on its own. I couldn't undo it. So, for example, if your project is affecting clinician behavior, then your framework should be addressing that level. So people have done the hard work of looking through all these different frameworks and where they fit into these three kind of categories of how to choose one. So this is just a list. It was in a It was in an implementation science journal where these researchers looked at dissemination versus implementation, the construct flexibility, with 5 being the broadest, and then the level of intervention. So if it looks like, alphabet soup up here, this can kind of help you characterize where you would start in looking at which frameworks might be helpful. And then lastly, thinking about the barriers and facilitators of the framework selection. So this one paper was looking at using a clinical support tool, but they actually incorporated using the framework into one of the barriers or facilitators, and targeted that a framework might not always work because of language, fit, ease of use, or evidence. So it might differ there as well. So thinking about how your framework fits into what you want to do. So now we've talked a little bit about selection, and then we're going to talk about how frameworks can be applied. And then this will all make more sense with some case examples. So first, frameworks are often adapted, and that's guided by aligning the population and setting to provide more specificity, especially for those frameworks that have that are very broad. And you might emphasize or de-emphasize constructs based on their relevance to the study. So one example of this is the REAIM framework, which is an evaluative framework, and it has 5 constructs that are in green here. And then the creators of the framework went back and thought about how the REAIM framework should be adapted more for equity-based projects, and that's in the yellow. So focusing on cost, culture, and context, and then equity itself are important to consider and might require adapting some of the constructs that you see in these frameworks. Second, often you have to combine frameworks. So you might need to use a determinant framework early on and an evaluative framework later. So there might be a need for multiple frameworks that might help expand the depth. So this specific example here is from a pediatric weight management program where they use CIIS for the early work and REAIM for the evaluative work. So sometimes you need both depending on kind of what you're doing and how you feel it fits your project. Often it's used temporally, so some constructs might be really important early on, like the barriers and facilitators, but others, like the evaluative frameworks, might be more helpful later. And so ideally applying a framework, the framework should be used at all stages. Again, you might have 2, but you might be using a framework throughout the entire stage of the research project. And it should be apparent in multiple areas of your protocol. So like when you're writing a grant, not just in the specific aims, it should be throughout the specific aims, the approach, and the evaluation. Ideally, the framework is included in all these areas, and the measures, the outcomes that you're looking for should be tied back to the constructs in the framework. So kind of looking at poor versus quality use of a framework. A quality use the framework would be respond to the research question you're asking and be linked to the question, the design, the strategy of implementation, and then the outcome measures, and be labeled throughout. Often a poor use of a framework is when the framework's only mentioned once, it's not driving the work, and there's no roadmap of how the framework relates to all aspects of the grant that you're writing, for example. And with that, I'm going to turn over to Kirsten to provide some case studies of how to use frameworks.
So this part is definitely best done in an interactive way. So please feel free to just raise your hand, chime in. I'm going to kind of be looking at the screen in case something comes up with the chat. So don't feel like I'm ignoring you, but I just don't want to miss the chat. as Katie said, we wanted to give you guys some examples of how this is used in real life, and especially across the entire arc of a project, not just writing the grant, but then also implementing it. And so I've highlighted here the ones that we're going to specifically look at. So you'll notice that the examples that we're using here were carried over from the first lecture, again, because the idea is we want to give you guys that sense of how the project goes across the entire lifespan. So the first project that we're going to talk about frameworks as a part of is this project that BMC was involved in to distribute naloxone in the emergency department. And this is going to highlight the use of CIIS, which is promoting action on research implementation in health services. I will put a little asterisk here that a lot of these original frameworks of implementation science has been updated. Like there's now an IPARIS, you'll see. There's also a CIFR and a CIFR outcomes addendum. And so definitely if you're writing a grant around this, make sure you're citing the correct version that you're actually using. Okay, so just as a little reminder, this project, like in implementation science, we start with identifying what is the evidence-based practice. And in this case, naloxone is a really good way of preventing overdose from opiates. The implementation gap, which is that people were not receiving this life-saving treatment. And again, this project was done sort of way before you could just pick up some naloxone at CVS. And so this project really tried to think about the ED as really the gateway to the healthcare system that a lot of people who are experiencing overdose or at risk for overdose interact with. And at baseline, only 8% of people were getting naloxone kits from the ED. So it's a big missed opportunity, big implementation gap that CIIS is well suited to tackle. So BMC conducted an intervention to provide these naloxone kits for people at risk of overdose during the course of their emergency care. And the aim of the study was to assess the real world effectiveness of the project and identify what could have led to low uptake of naloxone, which was what they initially found in the project, is that despite implementation efforts to get people to distribute naloxone, that it didn't actually work. And so they were sort of retrospectively going back and trying to understand why did this not work? And, if that had been thought about at the beginning of the project, maybe it wouldn't have been a failed implementation. So because of that, the selecting a framework that helps you identify facilitators and barriers, i.e. a determinants framework, is a good fit. And so CIIS is the one that was chosen. And so you'll see here that CIIS has 3 domains to help you understand why intervention was successfully implemented or not. And those fall under evidence, facilitation, and context. And so this next diagram gives a little bit of a sort of 3D representation of if you don't consider evidence, context, and facilitation, your implementation is going to fail. And if you're able to understand these and sort of consider them in your project's implementation, then you're more likely to have success with implementation. So in this case, I will say that in CIIS, when I started using it, I got very confused by evidence because I was thinking it very concretely oh, this is the strength of the evidence-based practice that you're using. And that is part of it. How good is naloxone at preventing overdose? That's a very small part of it. But it also includes things like how much do the healthcare workers who are the ones actually having to hand it out, how much do they believe that? Do they actually think? What are their preconceived notions about people who come into the hospital with overdoses? They think that they don't care about their own lives and don't want to live, then what is their motivation to actually take some naloxone and take the extra time to hand it out? So evidence sort of encompasses all of those types of beliefs. Context is really thinking about, again, and as we said in lecture 1, implementation science loves context. Other studies try to control for it and eliminate it. And so context is really trying to understand how is the ED environment different than, let's say, trying to implement this on the floor. And I'll say 2 weeks ago, some people from the addiction department came to me wanting to do a similar project of handing out clean injection kits to people at the time of discharge. And I referenced them to this to think about why did not work here? What's different about the inpatient context versus the ED? And so thinking about, how staff turnover, how the chaos of the ED influences how effective you can be in this is an important part of things. And then facilitation includes how the project was implemented, such as the type and the frequency of training, who did the training, how engaged did ED staff seem? Did they feel like this was sort of coming from the outside and being pushed on them, or was it sort of developed from within? So again, thinking about how you actually use frameworks. So you don't just want to cite it in the grant, get the funding, and then forget about it. You want to actually then take your framework and use it in real ways. So in this study, they did qualitative interviews, and focus groups, and they used the CIIS facilitation, context, evidence, codes and themes in their code book when they were coding those interviews and in how they interpreted them. And so through that, they were able to identify facilitators and barriers. And so what they found was that there were a lot of reasons why the project was not super successful at distributing naloxone. So in the evidence domain, they found that while providers believed in the efficacy of naloxone, they felt patients weren't receptive to it. And part of that is probably because you feel terrible when you take naloxone for an overdose, because you would immediately go into withdrawal. And so thinking about that part of things was actually important to think about how you sell it to patients. In terms of context, they found the need to clarify who was responsible for the distribution. So in the ED, it's sometimes the docs, sometimes the nurses who actually do the discharge teaching and like hand the paperwork over. So they didn't really think about, well, who is the like ultimately responsible for the ones handing these kits over? And then in terms of facilitation, they found that the intervention felt very forced, that they didn't really do a great job of engaging frontline staff in planning, and that the training was not very interactive and wasn't continuous. So it was sort of like a one-time thing. And if you didn't get it, you sort of were out of the loop. So this all could have been prevented if the CIIS model was used from the time of project planning to probably anticipate some of these facilitators and barriers. Any questions about this or how about CIIS in general? Okay, if anyone else has any other comments, feel free to chime in. So if there are no questions on that one, we'll go to the next one. So this is also another example that we talked about in lecture 1, which is the HepCap project. It anticipated going to the next one. So this was based on the implementation gap that Hep C screening is a really effective way of identifying and getting people into treatment who have Hep C, preventing them from ever getting to the point where they get cirrhosis. However, we were not doing a good job of screening people. And so they basically here, this was done in New York City, and they tested 2 different implementation strategies. So one strategy was doing birth cohort screening. So anyone who came into a clinic and was born between the years of 1945 and 1965, they automatically got screened for Hep C. You may have seen this then got translated over to Boston. When I first moved to Boston like 16 years ago, there would be bus stops that had, were you born from 1945 to 1965? And they're very attention grabbing. So that was implementation strategy 1. And then implementation strategy 2 that they tested was to think about like the actual risk factors for Hep C transmission and targeting screening to the people who had those specific risk factors. And the big implementation cap here was that there was really limited knowledge about which of these would be the best strategy for assessment and testing in the primary care setting. So this study used proctors, which is a measurement model. You can't get away from proctors in implementation science. In some ways, it is sort of like the origin of implementation science. And so you probably, this list that's in the chart under implementation, feasibility, fidelity, penetration, acceptability, sustainability, uptake, and costs are the backbone of like what outcomes we look at in implementation science. And this is where they come from, is from Proctor's model. And so they're very widely used. So much so that they are honestly just now called implementation outcomes, not even Proctor's model. The purpose of this is not to talk about measurement, but I wanted to give another example about how you actually sort of take your framework and then sort of integrate it into your whole plan of the project. And so if you're using Proctor's model as your implementation framework, there are official measurement tools to measure these Proctor outcomes. And so I cited here 2 different resources. One is called Implementation Outcome Repository, which is has a site that basically is just a catalog of validated tools for measuring these different outcomes. And then this other resource here is the Summary of Measures for Implementation Science, which is not just Proctor's, but the idea being if you're using this, you can go, for example, and let's say like you're interested in looking at feasibility, acceptability, and appropriateness of your intervention. So some of the sort of big names in implementation science recently developed these 3 validated measures for these implementation outcomes. And you can see that they are 4 questions each. They're on, you know, a scale of 1 to 5 of completely agree to completely disagree, and they're very quick. And so you can sort of cite these as the implementation outcomes you're going to use. And then when you're actually building your surveys, like these are the questions you put on them. And so that's sort of integrating it from framework to measurement. Has anyone used these or seen these before? I know Gabby, who's online, she used these in a study that she recently did in the NICU, and I'll be using them in a study that we're doing of improving discharge teaching for non-English speaking patients at BMC. Okay, so any questions about Proctor model or sort of how to use those? Any other comments that people wanted to make about that?
I think that might be a question.
Ah, thank you.
Just Gabby agreeing.
Thanks, Gabby. All right. So we'll keep going then. So the next one here is a study that was done that the BU Center for Implementation Science was involved in, at sort of looking at the safety net context for implementing interventions. And it will be an example of using CIIS, which is the Consolidated Framework for Implementation Research. Okay, so you guys may know that BMC is the largest safety net institution in New England, but obviously there are many safety net hospitals across the country. And there are some shared themes that come up when you're working in a safety net hospital, and anyone who's a clinician at BMC will probably feel that. Safety net hospitals are the ones that serve vulnerable, underserved populations, a lot of recent immigrants, non-English speaking, a lot of addiction medicine. So there's a common patient population, but then also because they are safety net institutions, they are underfunded. And so then you have similar sort of budgetary constraints that really then influence sort of how things like quality improvement, interventions, how just really what is like possible within these contexts, and what kind of implementation strategies and what approaches are going to be effective. And so here, the study was done where they basically conducted qualitative interviews with a variety of stakeholders, like leaders of safety net hospitals, and then the actual frontlines physicians and nurses, to think about sort of how implementation is happening in these contexts. And then the goal of this was to be able to draw from it shared lessons about sort of what kind of strategies are going to be effective in the safety net setting for someone looking to implement in that unique context. And so the objectives of the study were to identify and compare, again, the barriers and facilitators. And they looked at 5 different inpatient units in urban safety net hospitals. And then the sort of novel use of CIIS was that instead of being about a single project, again, it was trying to integrate findings across like very diverse environments. So this is CIIS, and I think that in implementation science, you either love or you hate CIIS. I actually love it. Mary Lynn, who's not here today, hates it. And so I don't think we've used it a ton within CIIS. I don't know if you guys have any preferences around CIIS. I love it. Okay, love it. Okay, all right. It was the first implementation science framework I ever used, so I also feel that might be why I love it. So it is another determinants framework. So again, good for looking at facilitators and barriers. It is very complex. And I think that's when people don't like it, that's why they don't like it. But I think you can also leverage it to your advantage. So it has 5 main domains. So you have the outer setting, which is sort of like your larger context. So in a lot of scenarios that if you're implementing something in a hospital, your outer context could be sort of the city of Boston, or your outer context you could define as the entire health system itself. Like if people work at BMC, you know that we're part of a very large system. We have an insurance plan, we have a network of community health centers. And so thinking about that whole big context. That is contrasted with the inner setting, which is sort of a specific area where you're doing your implementation. You then sort of have the individuals involved, and then you have the implementation process itself, which is that part at the bottom with the iterative arrows sort of showing the implementation process as it's going. And then So in this one, they call it intervention, and some other versions of this, it's called innovation. But one thing that I actually love about CIIS is that it takes the intervention, and when you think about it, it splits it into two parts, the core components and the adaptable periphery. And so since one of my interests in implementation science is how you adapt interventions, it actually is really well suited for that, because it can help you try to parse out like, okay, what is the part of this that's actually integral for making it function and making it evidence-based? And what is everything else that I can change based on my context and my patient population and my individuals involved? So I think it's kind of innovative from that perspective. I think more frameworks are moving in this direction as people are trying to adapt them for health equity implementation purposes, because again, inevitably, if you are in a low resource setting or working with a unique population on which your initial EBP was not based, you're going to have to do some type of adaptation to make it relevant. So if you go to CIIS.org, you will see that each of these has multiple subconstructs. So I counted, and 21 is the highest number of subconstructs for each of these one constructs. That doesn't mean if you're using CIIS that you have to use every single subconstruct. And I think that knowing that can give you like a little bit of mental freedom and hopefully make it a little bit more appealing. But they're really great because they have developed CIIS, because it's been around for a very long time and has been iterated upon. You can go to their website and they have qualitative interview guides that are already pre-written based on these different domains, so that you can pull questions about like, how do you measure your outer setting, your inner setting? In addition to the qual guides, they also have the actual code books that then you can use to actually code your qualitative interviews. So if you're using CIIS, I encourage you to take advantage of some of those resources, and just try not to get overwhelmed by the number of subconstructs. So in this study of safety net hospitals, basically what CIIS found is that there were multiple facilitators and barriers to implementation of interventions that were shared across these 5 different settings, that having this structure of CIIS allowed you to come to these conclusions that if you had no framework going into this, you know, probably you would not have been able to see as clearly. So they found that basically in the outer setting, that implementation strategies that didn't actually consider sort of patients' biopsychosocial realities were unlikely to be effective or had failed previously. In the inner setting, they found that the limited resources are a problem, but that in that setting, when you have limited resources, that things such as organizational recognition and financial investment is important as an upfront sort of precursor to implementation before you start. In terms of the individuals involved, they found that, and I think this is very true of BMC as well, that the individual actors' commitment to health equity is one thing that sort of ties everything together, that the docs and the nurses and the janitors, like everyone at safety net hospitals sort of believes in the mission, is here for the mission. And that's one thing that actually facilitated implementation of intervention. So engaging those individuals and trying to sort of lean on that personality characteristic. And then in terms of facilitators of the process of implementation, they found that a multidisciplinary task forces, so things like patient advisory groups, you know, not just having doctors, but having doctors, nurses, CNAs, a very diverse group of people when you're thinking about how to implement these is going to be important to actually make it successful. So I guess before we move on, any questions about CIIS or thoughts about it, or people who've used it?
General question, like, how do you get, I'm all on board for getting a diverse advisory board with both of all levels, but how do you get them to show up, like nurses and doctors? They're just too busy.
Yeah, I think that's a challenge always. I think so like I'm doing a project right now where that the Health Equity Accelerator is funding, and we're basically, for people who are discharged from the hospital who are non-English speaking, we hand them a stack of paperwork in English and say, here you go. And that's probably not the best way of doing discharge teaching, by giving people materials that they can't read. And so we're doing a randomized controlled trial where we're basically having our RAs take the materials that we give to everyone and create 3 language concordant discharge teaching tools that we then give to nurses to do their discharge teaching and go home with patients. So one of them is an audio recorder that we audio record the nurse reviewing the discharge instructions with the interpreter that they can listen to at home. So if they can't read the instructions, at least they can listen to that recording and know what happened. And so for this project, it's very important. I'm a physician, I'm not a nurse. very important to have physicians on board. And one of the issues is we have to get feedback from nurses about this project. And so I'm basically, by having a multidisciplinary leadership team for the project, she's the one that's going to like nursing managers on each unit and saying, okay, for your nurses on your unit, like, when can we talk to them? Or like looking at people's calendars and being like, this is your off day, let's set up a Zoom interview for you on this day. So I think like having those people as part of the planning process is necessary, because if I went in as a doc and was like, hey, nurses, like, talk to me right now, it's probably not going to be a super effective approach. So that's sort of my first thought, is just to have all the actors involved in the actual leadership of the project. I don't know if others have thoughts about what's worked in projects and CIIS projects you've worked on that front.
I think it's a good question, and sort of gets at another topic that I don't know if we'll talk about in our series of topics, but like community engaged research and using community engaged research as a strategy within implementation science. And I think like all of the things you said are true, like people have limited time. And so thinking about like what are ways to incentivize participation, like can we remunerate people for their time, and building that into funding proposals. Can we, have meetings at times that are maybe more accessible for certain members of the staff, or, if we're specifically targeting staff as part of this multidisciplinary task force. If we know that people, are in the hospital working 7 to 7, if they're nurses, or in the clinic, 8 to 5, can we have meetings in a time that is agreeable for people to show up? And also I think, making people feel and know that their contributions are valuable and being heard. So if we're receiving input from people, then coming back to them and saying like, this is what we're doing with your input, not just sort of like taking it in, plus minus, doing something with it, and not coming back to, your multidisciplinary task force to let them know how you're using their input.
I think, and talking to the person who runs the BMC patient advisory panel, that one thing that like doing interviews with the panel revealed is that parking is a huge issue to come to BMC for meetings. That's probably everyone, but just like creating easy access parking for people is one thing that made the patient advisory group a lot easier to sort of like come to meetings. So Emily has a question. You mentioned that with using CIFR, you don't have to use all the constructs and subconstructs, but how do you go about selecting which ones to focus on? So I guess I'm definitely on board with you don't need to use all the subconstructs. I think I would still encourage you to use all the major constructs, or at least think about them in your planning, because I think, as Katie pointed out, a lot of times these frameworks help you systematically think through a process and identify maybe an area of implementation that you would otherwise ignore. So I think in projects, when I've used CIFR, I've retained using all of these like 5 big domains, but just underneath each one, picking out the ones that make sense for your project. So, for the individuals involved, there's a lot of different ones that come up there around sort of measuring individual personality characteristics and traits, thinking about for inner setting, a lot of like the implementation climate, all these things. And so I think just like sitting down with the entire list at the beginning of the project and going through and thinking one by one, does this actually make sense for what I'm implementing, is probably like when I've done projects with it, the way that I've approached it. I don't know if other people, when they've been selecting a CIFR subconstructs, how they found it useful. That's been my approach. But I think the good thing is that, as long as you've thought it through ahead of time and built your project around that, I've never had a single reviewer be like, you didn't include every CIFR subconstruct, so therefore we're not going to publish your manuscript. So definitely not something you're going to hear. Okay, any other questions about CIFR?
Our has
Yeah. Hi, Kristen. How are you?
Good, how are you?
Good, thanks. I have a question about, frameworks for measuring organizational readiness for change, because that's what we're talking about, right? We can go around with like the best project ever, but it does not get implemented because, So
Yeah.
how do you measure that? And
Yeah.
what are the it's a very vague thing. I'm finding things in like the MBA literature and things like that, but not really in a medical setting. And I don't know how to measure it.
Yeah, so I think like the most commonly used tool for measuring organizational readiness for change is this one called ORCA. And it's a scale that can be delivered to like all different parts of a health system and done, multiple times during the implementation process. But if you go to this website, sorry, it's a little slow for me to go back on this version of this, but if you go back to that like implementation outcomes repository and look under implementation climate or organizational readiness, there's a couple examples there. I've never actually used ORCA. I'll say like the challenge of measuring institutional readiness for change is like upfront, you have to have a ton of buy-in and it has to be a huge project. And so like the VA is a system in which you'll see a lot that they like use ORCA to sort of measure like how ready this VA site seems and to adapt this or to implement this project that's been like slated for 20 different VA hospitals. So I think like that those are those ones, but I think when you're thinking on a smaller scale, which is the only type of IS I've done, I've never done like a huge VA multi-site study. So like one way that we're sort of measuring readiness for change in the project that I'm doing is like we're doing a very quick survey with nurses in the sort of pre-implementation phase, just asking them how much of a problem they think it is that like people who don't speak English don't get sent home with paperwork they can understand. And so that's not measuring all the different domains that ORCA would tell you to measure. But I think especially when you're doing single site or 1 or 2 site implementation study projects, you have to scale down some of your measures because it's just not feasible to do these huge ones that come along with the VA studies.
Thanks, Krista. That's very helpful.
Yeah.
Thanks.
Have any of you ever used ORCA or any of the other organizational? No.
But
Okay.
there are a few different measures you can use to measure organizational readiness to change. And I think I read a good systematic review of measures for this type of a construct. So it's out there. I've never used them, but there's different ones to choose from. And there are pros and cons to each. And
yeah.
So thinking through that, if it's something you want to assess prior to implementation.
Yeah. Any other questions before we move on to the next framework? No? Okay. So the next one's a good one. Sorry, let me just get this. There we go. Okay, so this is going to be an example of integrating 2 different frameworks. So this one looked at 4E. It's technically called Provenose 4E, but I've only heard of it ever referred to as 4E, which is a process model, and REAIM, which is an evaluation framework. So again, this is going back to one of the projects we introduced in Talk 1, which is looking at the role of CHWs in the care of patients with HIV and comparing the effectiveness for different models of how you actually implement CHWs within clinical care. So the project took place at 10 care sites across the country, which created a lot of complexity that the IS researchers needed to find a way to like organize and study. So the study is, you can see from the project timeline, it was a very long study that there was 12 months of planning, 18 months of implementation, 6 months of eval, and then a longer term evaluation. But it was what I would call a hybrid study. So the study's primary focus was to look at implementation outcomes, and the secondary focus was to look at the effectiveness of each of the different models of delivering CHWs. Okay, so before I go into the specifics of the 4E and REAIM, this model here shows you how the 2 were sort of used sequentially. And I think this is when you're combining frameworks, typically how they're done, as Katie said, is sort of 1 for planning and 1 for evaluation. There are examples of taking sort of 2 frameworks and overlapping them. And that's when I've seen it done, mostly done again for this equity adaptation, when you take a framework that's really meant to be at the individual or inner setting level and like expanding it to include the biopsychosocial model of health.
The health equity implementation framework is actually a good example of that.
Yeah.
Because it's either Paris or IPARIS, and then like a determinants of health or health and equity framework layered on top of it.
Mm-hmm.
And then the creators of the health equity implementation framework then like went and validated this framework by testing it in a couple of different sort of like studies.
Mhm.
But that's an exact example of what you're talking about, of like the layering and then creation of a new framework.
Yeah, exactly. And so the HIFE for short, Health Equity Implementation Framework, is, I think, kind of the best one that exists at this point, but there's definitely a need in the field to develop more. And that's something that our center is actually working on, is sort of developing another health equity focused implementation science framework and trying it out. Because having just one is kind of limiting, as you're seeing, because you want one that you want multiple ones that can apply in different projects. So the 4E is a process model, which was chosen to help describe and understand what each site was doing with its CHW program, again, as a way of trying to organize that complexity. And it really was more of a description that allowed the research team to identify all relevant stakeholders, to map the facilitation barriers to each step of the process, and then select and measure outcomes that would be tracked at each site. And then REAIM as an outcomes framework was used to identify and define measures for implementation success, but it is in no way explanatory. So it'll help you measure, but won't tell you why something worked or not. So REAIM have 5 constructs: reach, effectiveness, adoption, implementation, and maintenance. And so thinking about the other outcomes framework that we talked about, which is the Proctor model, you'll see some similarities here. So are there any categories that people see here that seem similar to the Proctor model ones that we looked at a few slides ago? I should have put them side by side to make this a little bit easier for you. So like, for example, maintenance is very similar to the sustainability Proctor outcome. So the being sort of like, does this just work in the first 2 months when it's new and novel? Or, 2 years from now, after the researchers left, is this still something that's going and effective? Similarly, reach here is similar to uptake in the Proctor models. So again, there's not always like one single best framework. You can, there can be multiple that are good fits. And so sometimes it ends up being whatever framework you're most comfortable with and have used in the past ends up being the one you select. So one really useful way to apply REAIM in projects that you're doing is to create a table like this, where you match the REAIM domain to how you will measure it in your project and and the sources that you'll use for that measurement. And so Mary Lynn and I recently were part of a team that was writing a grant for a pretty complex multi-stage intervention. And we sort of used this approach, and it really helped not only for myself organizing the evaluation approach, but also in the grant application, sort of showing how you're taking your models and directly applying it. And so this one is a little bit, I would say, compared to Proctor, there aren't as many sort of standardized instruments for REAIM as there are for Proctor outcomes, but that gives you more flexibility of defining for your project what like measures end up making sense. All right. Before we go on to our last example, or actually, I'm probably just going to stop there because I want to make sure we actually have time. So there'll be one more example here that's using Proctor outcomes that you guys can look at, but I'm just going to fast forward very quickly to this part, which is that I want everyone to make sure they have time to do the survey of the talks, because your guys' feedback is really important in terms of what you find helpful. And so if you guys wouldn't mind scanning this QR code and doing the survey, I'll then like open it up for questions, and happy to take any thoughts or feedback on what we talked about today. Just going to bring the chat up in case. I guess maybe as a last thought while people are filling out the survey, I was looking back at, there's a paper by Nilsson, I think, forget what year it was published, but it's one of the sort of foundational papers in implementation science that talked about why does implementation science rely so heavily on theories and frameworks. And there's a quote in there that describes sort of like when implementation science was starting, before we had these frameworks and models, someone was like, it seems like at best very expensive guesswork. And so I think that really like resonated with me about how these frameworks really do help generalize your knowledge. And it's a huge distinction that we talked about in lecture 1 between QI and IS. Often we use similar methods, we have similar aims, But QI is all about the one institution and doesn't attempt to sort of extrapolate lessons. And IS is definitely about that and sort of building on the work. So, you know, it's lecture 2 here because it definitely is kind of the foundation of everything that comes afterwards.
Kristen, I think you have the wrong QR code there.
It links to like a diversity clinical trial.
Oh, I'm so sorry. That's something else. I wrote the wrong thing in there.
Ooh, okay,
No, that's noted that. I don't want, I'll send it one there up there. So sorry.
sorry, that was our bad. We will, maybe, can we send it out to,
Yeah, we'll
Okay.
put it in the chat.
we'll put it in, oh, good idea. Okay, they're gonna put it in the chat right now. And then we'll also send it out to everyone who has signed up for today's.
The slides too, or?
Yeah, they're gonna be sending out the slides right afterwards. So that last example will be in there if people want to go through it.
No, that's embarrassing. I'm
While we're putting in the chat, one thing that Mary Lynn had said to me, or I think she said to us as a CIIS research group at one point, which I think was really helpful. There are so many theories and frameworks to choose from. And when you look at the list that Katie had pulled up on one of the slides, sort of like looking at construct flexibility and examination versus implementation, it can be overwhelming, it's like sheer volume. But if you choose to just maybe focus on like learning and applying like 2 to 3 a year over the course of many years, you know, hopefully in being an implementation science researcher, like you will become facile with many frameworks. And so I think that's been like something I have taken to heart because it can be overwhelming to sort of like sort out why you know, one framework over another and to be able to sort of like, you know, make determinations about when to apply one, but that has been helpful for me personally.
And a great reason, and probably the #1 consult question we get as CIIS is like, I'm doing this project, what is a good framework for it? And even people doing QI, now there's actually a big push in QI to start using frameworks, which is blurring the line between QI and IS even more. But definitely if you are thinking about a project, if you're going to submit a grant, definitely Gabby and I were just recently reviewers on some grants. And I will say our #1 criticism for every single one was like inadequate use of IS frameworks. So definitely a good reason to consult. All right. Well, thank you everyone for your time. If there's any questions, we'll linger for a while. And next session is November 9th about what's the topic? Study design. Fun stuff. All right. Thank you guys. Have a good rest of your day.
Okay, don't worry about it.
I should have checked.
And I did check if it worked. Over.